Good morning, Dr. C. Dr.
Good
Chandrasekar
morning.
Pranatharthi, who is one of the leading infectious diseases professors, who's from the Wayne State University in Detroit. We are very happy to have you here with us today at the Capstone Says. And we are going to ask your comments on a few things which have been going on in the States, where I think you are seeing a lot more cases than we are right now. So thank you very much once again for being there. And the first question is, what is really happening in the US? We are getting conflicting reports from the media regarding what Trump feels and what probably actually is happening. And what is your take? What are you seeing there right now?
Yeah, first of all, Ram, thanks for having me. It's a pleasure. It's about 11 o'clock in the morning here on a Wednesday. It's always good to see you, and thanks for the invitation. As for the COVID situation, I'm happy to say that compared to where we were 2 weeks ago or 3 weeks ago, the situation is very much better around the country. As you know, we have reached about 100,000 deaths this week in the United States alone. Out of the 300,000 plus deaths around the world, 1/3 of the deaths have occurred in this country, which is pretty tragic considering the resources and all that this country is supposed to have. Yet more than 1/3 of the deaths around the world have occurred here. I think overall, around looking at all the states, we have passed the prime in the majority of the states, primarily because of people have used social distancing, isolating themselves, washing hands, with simple measures is the major contributor for this so-called flattening of the curve. So we are seeing fewer cases. As an ID doctor today, I see fewer admissions into my hospital, patients with diagnosed COVID or symptoms of COVID. There are fewer patients going into the ICU. ICU is not overwhelmed anymore as it used to be, let's say, a month ago. In Detroit, the numbers are not as bad as New York City. I have been practicing in Detroit for over 3 decades now, and we haven't seen anything like this. All the city hospitals were overwhelmed. And as I said, things are slowly turning the corner, not because of a miracle drug, because of change in people's behavior.
Well, that's good to hear. But there's still a lot of thought about that the mortality is much higher than the eastern coast than on the western coast. And people say, is it because of a different type of virus, a serotype difference, or a mutation which has happened, which has made the East Coast situation much worse than the West Coast? What do you think?
I don't know. I don't think there is any obvious changes in the disease patterns between the two coasts. Are there differences seen? Yes, there may be some differences seen, but I don't think it is because of a mutation. Certainly that has not been documented, and we have not seen any such information from around the world. If there are mutated viruses behaving in different ways, it must have already happened in other countries, which has not been the case. So I will not attribute any difference in disease patterns to a mutation in the virus at this point.
Right. Now, regarding the treatments, again, it's going through a whole cycle of evolution where we started off with anti-HIV drugs, and then we started using anti-flu drugs. Then this moved on to chloroquine, then hydroxychloroquine, then newer other antivirals like remdesivir, favipiravir. And, it's still going on. There are claims from, for example, Bangladeshi doctors about the role of certain anti-parasitic drugs like ivermectin plus doxycycline, and the whole gamut of agents which are being tried. What are you using there? Do you think there is really a good agent for treating this virus?
No, not at this time. I don't think we have a proven effective drug. If you go into clinicaltrials.gov, you will see almost 200 clinical trials going on right now with a variety of different drugs, including antivirals, immunosuppressive drugs, immune augmenting drugs, like you said, antiparasitic drugs, corticosteroids, immune globulins. Today I got a protocol to do a study with itraconazole for COVID. And this is approved and it's in the clinicaltrials.gov. So just because somebody noted some in vitro activity, immediately it launches into a clinical trial. So it's incredible the number of clinical trials that have mushroomed, and people are looking at all sorts of compounds. But as far as we know, we do not have an effective antiviral drug to date. The drug that was mostly talked about, promoted by our beloved President Trump, was hydroxychloroquine or chloroquine. But now, as you know, the VA study, the recent international trial, all these have come out against the use of chloroquine, hydroxychloroquine, or a combination of these drugs with or without clarithromycin or azithromycin. So these have all, we used to use this in the past. About a month ago, every patient was on hydroxychloroquine, and we had it in our hospital protocol. Who should get hydroxychloroquine, not the chloroquine. We never used chloroquine. It was always the Plaquenil or the hydroxychloroquine. But now we have removed it from our hospital protocol, and we are actively discouraging people from using these drugs for mild illnesses as we used to. Now, the drug that has come into its place as a potential is the remdesivir. Remdesivir, as you know, the NIH trial has shown some efficacy. The number of days to recover was reduced from 15 days to 11 days. Again, there is no obvious mortality benefit. There is a lot of controversy whether the drug should be given in very ill patients or should it be used in the earlier situations. The study was done in ill patients, and they demonstrated some efficacy in terms of time to recovery. The drug is the data are being still analyzed. So I don't think there is a resounding support, at least the way the study was conducted. The general feeling is, yes, it may be helpful. Perhaps if you give it even sooner than the patients when they're very critically ill, it may have better benefit, but this has not been proven. That is problem number one. Problem number two, the drug is not available liberally. So the government took over the drug from Gilead. So the government controlled the distribution. So we have been given a small supply, and we have been given strict criteria as to how to use this product. In those criteria, we have been told only very ill patients should receive the drug. So we have been using it very sparingly, as most other centers, mainly because of the limitation in the supply of the drug. Yes, the drug may have some advantage, but it is not dramatic. It's reminds me of HIV. When AZT came along in the 80s, everybody said, oh my God, AZT is the wonder drug. But you know the rest of the story, how AZT was a very good drug at the beginning, and eventually we turned out to have much better drugs. So I think it'll be the same route we'll be following.
So at the end of the day, it looks like probably only paracetamol and oxygen are the...
There you go. That's right. That's right. Nothing like good old infectious disease principles. It's another virus, good supportive care, and taking care of all the other things such as nutrition, hydration, rest, all that I'm sure will play a very important role.
Right.
Particularly in people with comorbidities.
What about zinc and vitamin C and all that? Is it just
I don't know. Zinc, I'm a believer of zinc in the common cold. We participated in a study some years ago and demonstrated that zinc will have some impact against rhinovirus and coronavirus is causing colds. I do believe it shortens the duration of symptoms, and there is scientific evidence. This has been published, not particularly against SARS-CoV-2, but against other sister coronaviruses. So, and zinc is relatively benign, but you have to be careful what salt of zinc you're using, what dose of zinc you're using. I think in that setting, zinc may be beneficial. As for the others, I don't think there is adequate data at this point in time. I just saw a publication in one of the Indian journals about Ayurvedic drugs and homeopathic drugs in combination with a lot of allopathic drugs. None of those, I think, have adequate data at this time to support what they're claiming.
What about convalescent serum? That is the serum from people who have recovered from the illness and which may have antibodies. So, are you using it? Is it part of any study there?
Yes, it is available through Mayo Clinic Expanded Access Protocol. Through the government funding, Mayo Clinic has released this, and it can be obtained. We have used it in a few patients, and it's being used nationwide. There are at least 12 clinical trials looking at the efficacy of convalescent plasma. As you know, passive antibody infusion has been looked at for a long time for a variety of different illnesses, measles, mumps, influenza, a variety of different viral infections. We have looked at passive antibody infusion. And it has been beneficial mostly in the setting of prevention. So the question is, should I give plasma in patients who have been recently exposed to COVID? Would that be a benefit? So this is again an NIH study that is being looked at for preventive purposes of giving convalescent plasma in patients who are at high risk to develop the disease. Whether it's beneficial in the patients who are critically ill, we are infusing the drug in the ICU patients. It's all anecdotal at this time. We don't know. Most of the trials are just one-arm studies. They are not placebo-controlled. So I don't know if we will ever get good, solid, controlled data to support the use of this product. But people like it. They love the idea. There is some historical precedent to this. So I think there may be something to be said in a desperate situation. But I think if you follow old principles, I think it may be a better drug for preventive purposes, particularly in people who are exposed or at high risk at this time.
What about the vaccine? I think people are having a lot of belief on the vaccine because I think that's the only way it looks like this is going to end other than herd immunity. So do you think a vaccine will be available, a successful vaccine in the next 6 months to a year?
People are very ingenious. They are creative. And with everybody, so many different countries participating at this time, I am very optimistic. I'm an optimistic guy. Otherwise, you cannot be an ID doctor. Being an optimist, I think there will be a vaccine. The question is, how soon would we have it? Everybody is rushing. So as you know, when you rush, you're liable to make errors. So errors would be primarily in the arena of safety. If you start cutting corners, if you start to use the product, any product in large number of patients, you may miss the safety signals if you have very limited data, and the adverse events might start showing up when you start using the product widely. So that is the fear, and that is why in the past, a vaccine development took 10 years, 20 years through carefully controlled animal studies, followed by limited human trials to ensure safety before we escalated to a larger number of patients. But here, the mid phase and the late phases of vaccine trials have all been compressed now to the extent already manufacturing of the vaccines, even before demonstrating their efficacy, has already begun. And where is the manufacturing taking place? In India. The Serum Institute has contracted with Oxford University, and they are already optimistic that the vaccine that is undergoing investigation is going to be useful. And I am told that the Indian manufacturer has started making this product already. And there are several vaccines that are being looked at. The two vaccines that are in the forefront are the Oxford University vaccine, and the other one is an mRNA vaccine by Moderna Pharmaceuticals. The US government has invested heavily in all these vaccines, even before the efficacy. The Moderna vaccine has some preliminary data, as you may be aware. The preliminary studies seem to show the about 45 or 50 recipients of the vaccine had developed antibodies. And when some of these people were exposed to the virus, they did not develop the disease. They did not develop the infection. Again, ensuring the efficacy of these antibodies. So there is some very preliminary early limited data supporting the use of the Moderna vaccine. So there are two vaccines, there are different platforms, there are different kinds of vaccines being looked at, and the timeline is being compressed so heavily, both in terms of trials and in terms of manufacturing. So I am optimistic that there will be an effective vaccine. May not be a perfect vaccine, but a reasonably effective vaccine very soon. How soon? Listening to Dr. Fauci and others at the NIH, it appears it should be around by early 2021.
Right. And lastly, where do you think this is going to pan out, in the sense that we all know that we probably have to learn to live with COVID, but are we looking at 6 months? Are we looking at 1 year? Or are we going to look at a situation like the flu, which is going to be an annual occurrence and, frequent outbreaks? What is your take?
Yeah, I'm not a virologist, but an ID clinician. I'm looking at the behavior of organisms. This was an organism that has recently been introduced into the human population. As we have never encountered, it seems to have a devastating impact. Once more and more people experience the virus and it becomes more endemic, I think the virulence will become much more modulated. We'll have a symbiotic relationship with the virus, as we have with many, many other viruses. So it all depends upon how effectively we develop herd immunity over a period of time globally. And I think it is going to happen. And once that happens, obviously the virus will stop having a devastating impact on people in large numbers. And then we will learn to live with the virus, just like we live with many, many other organisms. How long is this going to take? I don't know. My guess is probably a couple of seasons. And then by the time there will be a sufficient number of people who become exposed, develop reasonable immunity, and then we may not see such devastating impact.
Thank you very much, Dr. C. That was very useful. Thank you for sharing your insights. I think a lot of people here will be happy to hear that you have a very, very sane approach to the whole problem, and what we need is probably behavior modification and learning to survive, this viral.
Absolutely. I think, there are many physicians here. You can see me, I'm in my scrubs right now. After the epidemic, I've started wearing scrubs to go see the patients. We still see the patients as long as you follow appropriate precautions, hand washing. I think we should be okay. There is a lot of hype about this and fear about this. As long as we follow reasonable precautions, and as the disease is waning, there is optimism, there is unnecessary fear should be overcome, And for us, it is our duty as physicians to give the correct information to the public, so the public is reassured, and it is unwise to take steps beyond what is reasonable, because we are all worried about the economy. People's jobs are at stake. So whatever steps we are taking should be within reason. And I think it is happening slowly. And as ID physicians and physicians in general, I think we have a responsibility not only to serve as role models, but also to spread the word wherever and whenever we can about what are the reasonable precautions we should take and where we should draw the line.
Thank you very much. I think on behalf of Capstone Clinic and myself and Aruna, we thank you very much for sharing your valuable insights and your time.